Okay, in this lecture, we will talk a little bit about drug elimination processes with emphasis on hepatic, as hepatic metabolism and renal, which is mainly renal excretion. The majority of whatever that we have here, you know it, with some extra notes from here and there. Okay, we will start with the hepatic elimination processes. We know before starting with the hepatic metabolism or hepatic elimination that elimination is mainly happening in two eliminating organs اللي هما liver well kidneys. We have mainly excretion in the kidneys and metabolism and the liver, and whatever is happening to the drug depends on its nature, its physicochemical properties. For example, we can find we have like main lines or guidelines of whatever is happening to the drug depends on its physicochemical properties. For example, lipophilic drug, we find it tends to be more bound to plasma protein, so but also get more distribution through the body because it's lipophilic, and lipophilicity increase the distribution through membranes or the uptake or transport through membranes, and also more metabolism in the liver through the enzymes, metabolic enzymes. For the hydrophilic drug, usually it's less distributed, so it means it's more eliminated through eliminating organs by excretion, for example. Okay, when we are talking about metabolism, we keep reminding ourselves with this, which is one of the main examples that we had, in which we have irreversible transfer or conversion of our entity of interest to another one, and it's irreversible. It's either we are having active to active metabolite, active drug to active metabolite, or inactive metabolite. Could be also inactive to active metabolites, such as prodrugs example. In the liver, we have we usually have the GI, okay, and from the GI we have the liver, and then we have the systemic circulation. Okay, so the liver is in between this is the liver, in between the GI and the systemic circulation. We have the lobule as the main structural unit or functional unit of the liver, in which the lobule consists of a group of sinusoids, okay, in which it consists of, you have the central, first of all, the we have the portal vein and the hepatic artery. So we have the hepatic artery, in which it transfers the blood into the lobule or the sinusoids in the lobule. And we have also mainly the portal vein, in which, again, see if this is the portal vein. Okay, so usually the blood enters the liver through those two sources, mainly through the portal vein, in which the blood will go through those capillaries or vessels into in which we have this surrounds what we call it, this is the sinusoid, but this surround what we call it the hepatocyte. Those are the hepatocytes or the liver cells, in which we will have a transfer between the blood and the hepatocytes of the material. In this case, we are interested with the drug. Okay, So this is the anatomy of whatever is happening, and for sure, after which the drug or whatever the blood will go into the central vein to the venous system. Okay, the liver, as we said, receives the blood from the portal vein. Here is the portal vein and the hepatic artery to have into the lobule that consists of sinusoids or sinuses, and then the drug will leave, or the blood, let's say, will leave with the venous system into the hepatic vein and vena cava. And by the way, the majority of the, if we are talking about the total blood flow, which is and it's an average one for 50 milliliter per minute, and the 70 kg adult, we can find that the majority of it goes through the into the liver through the portal vein. Okay, that's why we keep saying that the liver have the blood through the portal vein, because the majority of it goes through the portal vein. And as we mentioned, as I mentioned in a minute, that the drug will transfer from the blood into the hepatocyte in the sinusoids, and we can find or in the lobule, and we can find that there we will have in the hepatocytes, we will have metabolism through different enzymes, hepatic enzymes, or goes under excretion through the bile into the bile duct. And for sure, we have differences between subjects and in inter-subject or intra-subject variability in the metabolism of different drug, and also the pathophysiology of the individual matters. So we have differences between healthy and diseased subject, or between infant and elderly in the metabolism. For the metabolism, hepatic metabolism, we have two main phases, the phase 1 and phase 2 metabolism. In phase 1, we know that it's majority of it, it's actually the first step, usually it's the first step or the preparation step of the overall elimination of the drug. The majority, or one of the main process that occurs in the phase 1 metabolism is the oxidation through or via CYP450 enzyme. The phase 2, it's the usually it's either synthetic or conjugation reaction, and we have different examples of that, such as conjugation with glutathione, sulfate, glycine, glucuronic acids, and all other phase 2 reaction. And usually it's either follows phase 1 reaction and make the drug more hydrophilic to be eliminated. Most of the drug-drug interaction, or even drug-food interaction or drug-herb interaction, occurs at the phase 1 CYP450 enzymes or isoenzymes. And that's why you can find in drug-drug interaction or warning or contraindication something related to the interaction at this level. We can find that we have different phase 1 reaction and phase 2 reaction, and as we mentioned, one of the major metabolism processes related to CYP450, but we can find different reactions that could happen at those two phases. And with studying the drugs, we can find that different drugs are already, the metabolism profile of them is already known. And we can say, for example, that cyclosporine goes under hydroxylation and stuff like that. So once we study the drug and its pharmacokinetic, even before reaching the approval, we know the metabolism profile of each drug, which is one of the most important part of the kinetic to be studied. And the cytochrome P450 isoenzymes, we have a special nomenclature in which, for example, we have CYP3A4, for example. So this is cytochrome, and this is the first number, which is related to the similarities in the enzymes in which the genes of them are similar with 40% or more. The letter, so we call it the family, the letter which is related to the subfamily of the enzymes in which more than 55% of their genes are common or similar, and the subfamily or the more specific part or group of it is the last number, which is in which the enzymes have more than 97% of the similarities in the genes. So the nomenclature between different groups is related to the genetic similarities between different enzymes. That's why we subdivide them into different groups accordingly. According to different isoenzymes in CYP450, we know that we have different substrates that are metabolized by those enzymes. We have non-inhibitors and non-inducers, so that's why we have the drug-drug interaction usually according to the whatever is happening at the site of those CYP450. Okay, for this graph, we can see in A, if we are talking about the presence of the majority of the CYP450 enzymes, we can find that CYP340 is present in 28%, or in the human liver, considered or covered 28% of the enzymes. 2DC is 2% of the enzymes, okay, as majority of the enzymes or not, or the percentage of abundance of those enzymes compared to, for example, 2C9, which is more or one of the major enzymes. But when we go and see the how much those 2,3A4 and 2DC, 2D6, contribute in the metabolism, the hepatic metabolism, we can find that 50% of the drugs, at least in this study, is metabolized by 3A4 and 30% by 2D6. Take-home message from this that even the presence or abundance of those enzymes is not that much according to whatever is there in the hepatic enzymes, or among the hepatic enzymes, what we care about, what is the usually the majority of the drug metabolized by what. So we can see that 28% covers, which is not that much compared to whatever is there in the enzymes, hepatic enzymes, but could cover 50% of the drug metabolism. And same for 2%, which is very low as abundance percentage in the hepatic enzyme, and could cover as percentage as large as 30% of the drugs. So it depends of, even it's not present that much in the hepatic as enzymes, but it's covering the majority of the metabolism of drug metabolism, usually when it was studied or let's say analyzed in different drugs. So for the hepatic clearance or factors affecting the hepatic clearance, there is so many factors affecting that. We talked about part of them before, but extremes of age, which is something common sense because the differences in the metabolism changes with age. That's why we have some cases in which, for example, chloramphenicol had the case in neonates in which they were not able to do the conjugation or the metabolism efficiently. So we had severe toxicity caused by the drug. Social habits, and that's why when you visit the MD, they will ask you different questions related to drinking alcohol or smoking either cigarettes or hookah, because it's affect the hepatic clearance. And the case for alcohol and smoking, for example, it's cause an induction increase in the hepatic clearance because of the induction of some metabolic enzymes. So that's why the smoking or drinking is one of the major factors that we should take into consideration in our patient. Disease states that could affect the liver directly, such as liver cirrhosis, which make it not efficient for the liver to work through metabolism or elimination pathways. Disease state that would affect the liver indirectly by affecting the liver blood flow, such as the heart failure. If we have heart failure, then the cardiac output to the liver would be affected. So accordingly, the clearance would be affected through the liver. The concomitant drug use, and this is related either to the presence of inducers or inhibitors, as we mentioned in a minute, in which if we are having inducer, then it means that the metabolism of the drug of the drug of interest increases, rather than if we are having concomitant use or administration of inhibitor. This would decrease the metabolism, and accordingly what this effect would be on the total concentration of the drug, because if increases in metabolism, then this is expected to decrease the concentration of the drug. If decreases in metabolism, is expected to increase the concentration of the drug. And what that effect on the final concentration that causes the response or the therapeutic effect should be taken into consideration or corrected, or we need to correct for that. Genetic polymorphism, and it's one of the major problems that we have, or let's say factor that we need to take into consideration in metabolism, because polymorphism is taken into consideration differences in the genes that could code for different enzymes. And one of the main examples of that is the 2C9 and warfarin case, in which we have, for example, the metabolism of Caucasian to warfarin will be different than other races. That's why large number of Caucasian would have increased anticoagulant effect of warfarin. That's why the dose should be corrected for that. And again, this is caused by polymorphism, because the 2C9 or the genes that encode for the metabolism of the enzymes that metabolizes the drug is different. Another example, which is the acetylation, we have the fast acetylator and fast acetylator and slow acetylator, and again it depends on the rate of elimination according to the acetylation process. For the hepatic metabolism, if we are talking about linear kinetic, you know that total clearance equals renal and non-renal, and if the majority of the non-renal is happening in the liver, that's why it will be majorly happening in the liver. That's why we call it total clearance equals renal plus hepatic clearance under linear kinetic for sure. Okay, we have physiological definition of the clearance, in which if we are talking about certain eliminating organ, we can determine the clearance by the flow to that organ multiplied to the extraction ratio by that organ, in which we can determine the extraction ratio by the concentration entering and leaving over the total concentration which is entering. And we know that the range of the extraction ratio from 0 to 1, in which this is 0, it's non-eliminating organ, and 1 is the fully eliminating organ, and in between we may have low or high or intermediate extraction ratio drug. For the extraction ratio less than 0.2 We call it, when we are talking about hepatic extraction, low hepatic extraction ratio, in between intermediate and higher than 0.8 high extraction ratio. And remember that we said that the cutoffs of those ranges depends on the reference that you are studying, or to which extent you want to be restricted, more restricted, or less restricted. And this course, we will consider this one that you have in the slides. So this is low, intermediate, and high. Okay. For the hepatic clearance and intrinsic clearance, if you remember, we had it under one condition, in the absence of the protein binding. Okay. And when we had this, we mentioned that we can talk about the intrinsic clearance in terms in the extraction ratio in terms of intrinsic clearance, which is the ability, the inherent ability of the organ to metabolize the drug in the absence of any limitation that is related to the flow or the perfusion. And when we had it math-wise, it was the flow multiplied to this term, the flow of the hepatic, in this case, intrinsic clearance of the liver over the flow of the hepatic plus intrinsic clearance of the liver. And we had two extreme cases. And again, we are still talking in absence of protein binding, in which the flow to the hepatic is larger than that of the intrinsic clearance. And we mentioned that directly you can know that as this is the slowest process, that the rate limiting step in this case is the intrinsic clearance. Okay, and if you can go through it of whatever is happening here, we can know that the hepatic clearance is almost equal to the intrinsic clearance of the liver. And we can know that by, if it's this very low, we can neglect it, and then the flow from each side would be striked out to have intrinsic clearance only. And we did this already before in 456. Okay. If we have the opposite, which is the flow is very low compared to the intrinsic clearance, which happens in high extraction ratio drugs, it means that the rate limiting step in this case is the flow, hepatic flow. And this is why the flow of, or the hepatic flow, clearance of that drug would be almost equal to the flow to the hepatic. Okay. The only addition in this course is, what if we are taking into consideration the protein binding, because we can't ignore the protein binding all the time, right? Sometimes we have some protein binding and we need to take it into consideration. We have this model of the clearance, and we call it well-stirred model, or other names, jar equilibrium model, venous equilibrium model, or well-stirred model. And we, in this model, we are assuming that we have direct or instantaneous venous and hepatic equilibrium of the free drug. Okay, so that's why we are assuming that we are under well-stirred model. Okay, the only thing that we need to take into consideration, that we need to take the free fraction or unbound fraction of the drug, because we are talking about the unbound equilibrium with the unbound fraction of the drug. And to do so, we multiply the intrinsic clearance in both parts of the equation to the fraction unbound in the plasma. Okay, so the only addition to the equation is this, which is the fraction unbound of the drug in the plasma, or the free fraction of the drug. Okay, so we are talking about the term or the equation in the presence of plasma binding. And again, we have two and by the way, the other terms, it's the same as you know. We have two extremes, or two ways to look at it, as the two sides of the scenario. If the hepatic flow is very low compared to the intrinsic clearance, in this case, this is our intrinsic clearance, and this case happens if the extraction ratio of the drug is high. An example on that, the high extraction ratio drug, it means that the rate limiting step again is what? The hepatic flow, and that's why the total hepatic clearance would be equal to the hepatic flow. And you can do it by equation as mentioned before, and just write with yourself. If we are talking about hepatic flow that is larger than the intrinsic clearance, it means that the rate limiting step is the intrinsic clearance, which is the free fraction multiplied to the intrinsic clearance. And that's why when you do the equation, you'll find that the hepatic clearance equals the intrinsic clearance. And as this is the rate limiting step, examples on that, drugs with a low extraction ratio drug. Okay, so the only difference again that is happening here is just only that we are adding into consideration or taking into consideration the unbound drug or the free drug. Okay, and again, we can have drugs with high intrinsic clearance, with drugs with intermediate or low intrinsic clearance as before. For the first pass effect, we know before that we can, if we have different fractions, sequential fractions, surviving each part of this, let's say, pathway to reach the systemic circulation, we can determine the absolute bioavailability of the drug or a fraction of the drug reaching the systemic circulation by the sequential multiplication of each fraction of those. Okay, and this something that we already mentioned before. Okay, and if we want to determine the vice versa, to use the to use bioavailability to determine the extraction ratio, especially if we are talking about the hepatic extraction ratio, we would use the calculation of the bioavailability to determine the extraction ratio if we consider that the non-hepatic fraction of metabolism is negligible. Then we can determine the extraction ratio by just subtraction the bioavailability, absolute bioavailability from 1. Okay, and I'll stop here, then I'll continue in this